So we're going to move on to our main event today, talking about mental health first response. So I'm going to bring in our speakers. We've got from Integral Care and from city staff. Okay. Let people's videos turn on. So as I like to start every meeting, just as a technology check-in, I am the host of the meeting. I will mute you if you forget to mute yourself. Don't take it personally. We will have our presenters. We've got a slide deck from Integral Care and a slide deck from APD. I think both of them are probably good to go through. For the council members, the intention here is to also present information that the public may not know. So I know most of us will know the stuff that's in these presentations, but I think it's a good kind of reset on the information for the public to see this from the budget votes we took last week. So we'll start with Integral Care and then we'll do our APD presentation. It's probably wise to let our presenters make it all the way through and save your questions to the end, and then there should be plenty of time for conversation. Does that sound good to everybody?
Councilmember, I just got a message from Dawn Hanley. She got disconnected. She's logging back on.
Okay. Yeah, she's got Councilmember Harper Madison.
Thank you, Chair. I appreciate you recognizing me. There was something that I wanted to make sure to say before the meeting ended, and this seems like an appropriate place if we're having a little bit of a issue with somebody getting back in. I had the opportunity to, between Friday and Sunday, have more than a dozen conversations with people in law enforcement positions. And those conversations were very much about them feeling like they are in the dark about what is taking place, and me recognizing that we're talking about people's livelihoods, in which case they should definitely not feel like they're in the dark and should definitely not feel like they don't have the opportunity to ask questions. So with this opportunity and your recognition and my ability to speak on it, we 100% need for law enforcement professionals to know that our access to city legal is not exclusive to city council. You have access to city legal as well. If there are any questions that you have about what you can and can't ask in your role by way of the contract that we have, ask city legal. If you don't know whether or not you can ask a question, if you don't know whether or not you can say a thing or not say a thing, ask city legal. You have access to them just like we do. And most importantly, you have access to the city council. I've talked to multiple law enforcement professionals who didn't realize that it was an opportunity that they have to even talk to us. They don't know they can talk to us. That is so problematic. So I just wanted to make sure to say publicly, you guys, you have access to us and you have access to city legal. If you have questions about your really difficult job and the things that we as a council, as a body are doing that affect your job, your livelihood, you absolutely can ask us questions and you absolutely can ask city legal questions. And so I just don't ever want to be put in a position again to where our law enforcement professionals don't know that they can ask us questions, that they can be a part of this process. They absolutely should be a part of this process. And the fact that they don't know that their leadership, both by way of APD and by way of APA, aren't letting them know that they have the opportunity to ask us questions, to be a part of this process of us being, we are the trendsetters. We're going to be the revolutionary municipality that gets it right. I wholeheartedly believe that. And we cannot do that without them contributing to the process. And if they don't know that we wholeheartedly welcome their contribution to the process, I thought, why aren't we hearing from y'all? And what I was told by more than a dozen people over the course of the weekend is that they didn't know they could be a part of that process. They didn't know they could talk to us. They didn't know they had access to city legal. That is extraordinarily important. So just want to make certain to put that out there on the record, public facing. Y'all have access to us, and we all, and not just me, we all welcome you reaching out to us. We want you to reach out to us. We want you to be a part of this process. So don't for a moment listen to anybody who says otherwise, because it's not true. And that was all. Thank you, Chair.
Thank you, Councilmember. Mayor Pro Tem, did you have your hand up?
Yeah, I guess Councilmember Harper, if you can just provide context for what that means to them, because if I was a police officer listening, I don't know what you have access to city legal means. And I could understand, I know in the fire department there's a very strict chain of command that firefighters are supposed to follow, as well as, and I would assume it's the same for police officers. And so maybe this needs to be some kind of official memo that they have access to. Obviously, I have always welcomed and had conversations with police officers and told them that I to the extent that I can keep things confidential, but then there's any emails we get sent. I just want to be careful of what we open up, because they have to know that if anything they send through city email is open records, any kind of text message is open records. I just think I think it's good to make a statement like that, just to make sure they know what the parameters of that request to them or that invitation to them is.
I think you more or less said it, right? I appreciate that context, because in terms of parameters, right? Yes, anything that you send to our austintexas.gov emails is open to public information requests. I think some of the questions, though, that I was being asked are really basic questions that we should, in fact, just be providing by way of a public-facing memo that answers some of their questions. So people are asking me questions along the lines of whether or not their jobs are in jeopardy, whether or not they can ask us a certain kind of a question. They just don't know how and when they are able to interact with us as a body, how and when they can interact with us as a committee, how and when they are able to interact with city legal. And so, yes, obviously, I would say I appreciate your reminder about discretion. There's nothing that you could say to us at our austintexas.gov emails that won't be public record if somebody wanted to make it so. But the basic questions, like some of the questions that I received over the course of the weekend, are so very basic that it made me feel bad, frankly, that the police department leadership, the APA leadership, that frankly, us as a municipality, we are not communicating with them in a way that they don't know anything. They really feel left in the dark right now. And as we, are on the precipice of this revolutionary, transformative change, I really wholeheartedly believe that there are other cities that are going to look to us for how to get it right. And if we're going to do that, then everybody has to be a part of the process. And I feel like they don't recognize that they can, in fact, be a part of the process. In which case, I think contextually, what I'm trying to say is they have access to us. There's no reason why they can't communicate with us, why they can't testify before council, why they can't ask city legal questions about, the parameters there. Like you very, eloquently stated, there are parameters. They are city employees, and there are rules by way of their contract, but they don't even know that they can communicate with us. And I find that problematic. And so that's what I was trying to highlight and put some daylight on. Hopefully that helps.
I think it will be good to get to our agenda. Councilmember Kitchen, I think Assistant City Manager Ariana wanted to make a comment as well. But I would like to get us to our agenda. So, Councilmember Kitchen, if you want to go quick.
I'll be very, very quick. I just want to thank Councilmember Harper Madison and also Mayor Pro Tem for the comments. And just because I think it's important for our police officers to hear from all of us, I just want to echo those sentiments. I want to say personally thank you to our officers and their families who serve this city, and they're dedicated to keeping people safe. And then I want to just say to our Deputy City Manager, Nuria Vandermeyer, I want to say to her that as we go through this reimagining process, the voices of officers are necessary voices at the table.
And we have in fact had officers join us in committee meetings in the last couple of months too. Ray?
Thank you, Chair. And I just wanted to leverage off these comments. Again, Councilmember Harper Madison, you and I had a brief conversation about this, and I'll get back to the department to make sure they're communicating what is happening and what they can expect or not expect in terms of potential effect to their positions. On behalf of certainly the Deputy City Manager and my colleague, Assistant City Manager Chris Shorter, as we form the core leadership team and work with the city community reimagining task force, it is our intent to include the voices of those that are on the front line, the police officers, in this process. And so rest assured, we will follow up on that.
So I think like Beetlejuice, it's only fair if you say someone's name 3 times, you got to bring them into the meeting. So I think our Deputy City Manager is here.
Well, Beetlejuice appears. I appreciate it and only want to say, I think Ray has said it, but in fact, we have, not only do we anticipate meeting with all our officers, and I know that the city manager earlier last month even sent a note to all of PD saying that they should expect HRD and ourselves to have meetings with them. And so we are following up. We have a meeting, or several of us have meetings independently and together with victim services, internal affairs, support staff, 911, and forensics already in the works, most of those planned. And we will continue to go throughout the department to get information from staff. We cannot do this work without hearing from everyone's voices, and everyone's voices includes the police department.
Okay, let us get to the meat of our meeting today. Dawn, I see you have a video turned on, but I don't see you. Are you there?
I am here. I'm having some trouble with the video, so I'm not sure I'm going to be able to resolve it before my presentation.
That is perfectly fine. I am sharing the slides. Can you see them?
I can.
Great. So Dawn, why don't you introduce yourself and take it away.
Sure. Hi, I'm Dawn Hanley. I'm the Chief Operations Officer for Integral Care. And I'm going to thank you for the opportunity to speak today. And today we'll be covering some of our mobile crisis response. Next slide. So Integral Care supports adults and children living with mental illness, substance use disorder, and intellectual and developmental disabilities. And we help people build health and well-being so everyone has the full foundation to reach their full potential. Next slide. So today we're focusing our conversation on our mobile crisis response. And I think it's critical that we remember that when someone in our community is experiencing a mental health emergency, that we see and value it as a healthcare emergency. Integral Care's mobile crisis response consists of 2 teams. We have an expanded mobile crisis outreach team, or EMCOT, and we also have a mobile crisis team, MCOT. These are specialty teams of our mental health professionals that go anywhere someone needs help in the community. These teams provide community-based follow-up services for up to 90 days after the initial crisis, and they ensure that a person is supported throughout the duration of the crisis and link them to ongoing services. It's important to note that these mobile teams are following the essential principles outlined by SAMHSA, the Substance Abuse and Mental Health Services Administration, to provide site-based psychiatric crisis and crisis assessment, access to a prescriber as needed, diversion to appropriate community-based care and resources, and short-term follow-up to ensure that individuals' immediate crisis is stabilized and the individual is linked with ongoing care and resources. So the reason that we follow people for 90 days is because a crisis doesn't resolve in one interaction. It takes time for people to stabilize and recover. And many people who experience a mental health crisis need ongoing services well beyond the 90 days. So without these ongoing outpatient clinic services and their basic needs being met, many people will continue to have a crisis, which will impact their health outcomes and local public systems. Next slide. In looking at our two teams, both MCOT and EMCOT provide the same type of clinical services as outlined by SAMHSA that I previously went over, but the main difference is really how they're dispatched. So EMCOT was formed in 2013 and is now funded by the City of Austin and Travis County. It's our largest team, and it was designed to work with first responders and justice systems to divert individuals from unnecessary incarceration, emergency department use, emergency detentions, and psychiatric hospitalization. This team is exclusively dispatched by 911 through the request of law enforcement and Travis County EMS. So beginning in this fiscal year in 20, this team was also able to provide a clinician on the floor of the 911 call center to field incoming mental health emergency calls in order to minimize the dispatch of a law enforcement officer in response to a mental health call. EMCOT also co-responds with first responders. They provide mental health training and they provide telehealth support. Now, MCOT is about half the size of EMCOT. It was developed in 2006. It's funded by Travis County and the state of Texas. This team is only dispatched by Integral Care's helpline or hotline, and it is a requirement of the state. So MCOT fields referrals from our helpline based on calls they receive from anyone in the community, including individuals who are having the mental health crisis, family members, or it could be an organization such as a school that gives us a call. Next slide. This diagram is showing a visual of the 911 center pathway, trying to give a look of where we were, where we are, and then where we could be in our collaboration with our first responders. So somewhere between the where we are now and where we could be really represents the requested model or our expansion of EMCOT. It's been a longstanding goal to have 4 options when people call 911. So do you need police, fire, EMS, or a mental health professional would be the optimal goal. In order to support this endeavor, Integral Care requested funds to expand personnel and hours of availability to 24/7 at the 911 call center and in the field. So in order to provide diversion opportunities at the time that someone is calling 911 for a mental health emergency, EMCOT will designate 2 clinicians to be on the call center floor at all times. So this change will strive to decrease wait times for callers, and it will increase the number of calls that EMCOT can assist with. At least 1 clinician will be stationed at the APD section, and we're working to have at least 1 clinician also stationed with the EMS section. So both of these clinicians will be responsible for facilitating calls that are transferred by both APD and EMS. So building on the existing collaboration between EMS and EMCOT, Integral Care also proposed pairing EMS community health paramedics with an EMCOT clinician overnight to expand community-based capacity to provide mental health crisis response for coverage for 24/7. The total expansion involves adding additional staff. So we're going to be adding 6.5 staff to cover the 911 call center aspect of the operation, as well as 3.5 staff to co-respond with EMS. So far this year, EMCOT stationed at the call center has been able to divert 85.4% of the calls from law enforcement. So with this new expanded model, it'll allow us to improve and build on that success. Next slide. So the current model that we have with EMCOT, it costs $1.8 million. That's what we're doing today. And this has 1 clinician stationed on the floor of the 911 call center in the APD section. So you can see in each one of these bars, it gives you a snapshot of what the staffing pattern would look like in each one of those years. And so the FY 2021 proposed model is a surprise, and I'll get there shortly. So the requested model where we ask for additional dollars to expand MCOT for FY 2021 is partially scales the project, and it does allow us to have 24/7 coverage at the call center. So this request was an additional $1.3 million. So that'll bring the total budget for next year to $3.15 million. So the proposed model that you see up there would be the wish list, or the something to strive for as we look towards the future. In this proposed model, it's an example of what it could look like if the project went fully to scale, and it would enable MCOT to cover 100% of APD, EMS, and 911 mental health related calls. So this model is estimated at about an annual program operating cost of $6.2 million. In a fully scaled 100% model, we envision altering the MCOT response a little bit with funding. All EMCOT clinicians who are assigned to respond to the 911 dispatches would be paired with community health paramedics. More specifically, this would represent the 911 dispatch involving a community health paramedic and one MCOT clinician riding out together. This would allow for a timely response in a first responder vehicle with one mental health professional and one paramedic who specializes in community health to provide us with an integrated health response. Next slide. So that takes us to the system of care. So the impact to the system of care is a person doesn't live in crisis, right? We don't want them getting their ongoing care in a crisis model. They need specialized services and ongoing support to regain health. They need to be connected to a health home, and the public system really lacks capacity to receive a higher volume of people who need step-down services and ongoing support. So Integral Care is open and committed to growing the EMCOT model so that we're available as the first response unit together with EMS for 100% of the mental health emergency calls in Austin and Travis County. However, to improve the health outcomes and reduce the impact on the public system, it's essential to consider what happens after a crisis. So I took a look at our current data, and at approximately 60% of the people who are experiencing a mental health crisis that we are serving through EMCOT needs ongoing supports in a public system, and they have no source of funds or any way to cover the cost of their care. So increases in crisis dollars need to really be coupled with an increase in outpatient ongoing services. Integral Care's outpatient services can't continue to accommodate the influx of people who enter through the crisis system and need ongoing support without a way to expand our outpatient capacity. By way of example, ongoing supports for the outpatient behavioral health services projected to be needed for next year just to accommodate the FY21 expansion is about 1,680 people, and that cost comes to about $8 million per year. Any further consideration of expanding mental health crisis response, such as what's shown in the 100% response being fully scaled, needs to be coupled with an expansion of ongoing outpatient to reduce repeat crisis and to make sure that we have access available for these folks. In closing, there's rapid population growth in Austin and Travis County, and coupled with our response to a pandemic, it's really placed greater demand on first responders and behavioral health outpatient services. And when someone in our community is experiencing a mental health emergency, it is a healthcare emergency. Building on existing collaborations between EMS and MCOT to bring integrated specialty care to individuals experiencing mental health crisis, it really is the role of the mobile crisis outreach teams to expand and be that first line response for all of our health emergencies. In addition, we need to keep an eye forward to the supports that are needed for families and individuals beyond that crisis. Thank you. That concludes my report.
Thank you, Don. Really fascinating information. We also have a presentation on the crisis call diversion program. And I don't know, Assistant Chiefs, who your intention is to handle this, but I have your presentation ready to go. Who wants to go?
I believe APD has that. There you go.
Hey, this is Assistant Chief Chacon. Thank you, Chair and committee members. I just want to open up with a brief statement regarding APD's involvement. APD has long recognized that people that are in mental health crisis, that is a health crisis and not a criminal type of issue that the police necessarily need to be involved in, and that we should be and are looking for ways that we can divert those calls so that there is no law enforcement response. I think that everybody recognizes There will be those outlying cases that violence might be a factor. And for those, obviously, a police response might be necessary, and we'll work with the program to make those appropriate responses. But we really believe that the way forward begins at first contact, which is the 911 call. And that's what this crisis call diversion program is really all about. I'd like to bring on from the APD side, Lieutenant Ken Murphy, who is our manager at CTEC and manages this program, to go ahead and run through the slide deck. Thank you.
Thank you, Chief, Chair, and council members. So our crisis call diversion program started last year. We started collaborating with Integral Care and EMS in September of last year. And we traveled to Dallas, we traveled to Houston to take a look at their mental health programs and their clinicians embedded on their operations floor for the 911 centers. And what came out of it was truly a unique program we developed just for Austin. In Dallas and Houston, there's no true diversion. The crisis counselors will speak to folks in crisis on the phone. However, they will still send a team of a police officer, an EMS paramedic, and a crisis counselor. What we developed here was a true diversion program. Next slide, please. So the crisis call diversion program, in short, CCD, focuses on diverting appropriate mental health related calls received by APD's Emergency Communications Division to a call center clinician, which we nickname C3, who is embedded on the operations floor. The goal is to engage the caller in addressing mental health issues in the mental health treatment system as opposed to the criminal justice system. The C3 position will serve as an add-on service and does serve as an add-on service to a 911 operator answering a call with a suspected or confirmed behavioral health crisis component. Next slide, please. The C3 provides the caller with complete triage screenings, assist with de-escalation of crisis, complete safety planning, dispatches integral care crisis teams, EMCOT, and provides other community referrals as necessary. If the C3 determines the caller is in need of immediate services or the caller still requests law enforcement response, the C3 will connect the caller back to our 911 operator, and the 911 operator will dispatch police officers. Next slide, please. Currently, the crisis center counselors, the C3s, are available Monday through Friday, 8 a.m. to 12 a.m. and Saturdays, 10 a.m. to 8 p.m. Our future expansion, as Don mentioned, includes having C3s available 24/7. And when we have C3s available 24/7, we will add on the fourth question to the triage of do you need police, fire, EMS, or mental health services. The C3s work on the operations floor and here at communications, and they log into our computer-aided dispatch and our Solocom 911 systems to receive direct transfers from the 911 operators. It speeds up and simplifies the transfer and call process. Next slide, please. Some criteria. Calls are not eligible for C3 intervention if an individual is in possession of firearms, knives, or any other weapons. And by possession, we mean physical possession at the time, not they have a knife or a firearm or a weapon in their home. But if they're actually in physical possession of the weapon at the time of the call. An individual under the influence of alcohol or drugs to the extent requiring medical intervention, i.e. an overdose or detox situation, or exhibiting violent behavior. And as a note, generally, EMCOT or PES can assess a person who is intoxicated or on a mood-altering substance if they can, 1, stand without assistance, and 2, participate in the assessment in a meaningful way. Also ineligible for transfer are individuals threatening or at imminent risk of hurting self or others, or of killing themselves or others. Now it's imminent, meaning they are in possession of a weapon and they're threatening to hurt themselves immediately, not just contemplating suicide or contemplating hurting themselves or someone else. When an individual has committed a crime, in other words, family violence, if a crime has been committed and an officer must respond to a call, and we're not just talking about the minor crimes. We're talking about a crime involving violence. Also ineligible are hotshot calls where life and or property are in imminent danger, and priority 1 calls, with the exception of check welfare urgents, if the call does not have other disqualifiers. Next slide, please. Calls eligible for C3 intervention: callers experiencing a mental health crisis and not actively attempting suicide or physically violent towards themselves or others. Callers indicating there is a verbal dispute or disturbance only with a mental health component, which a C3 can potentially resolve with intervention and there is no risk of violence. Callers requesting police due to psychosis or an altered mental state and are not physically violent toward themselves or others. Parents requesting police due to child behavioral issues, regardless of whether the child has a known mental health diagnosis. And parents requesting police to assist with child discipline or parenting issues. Also, we receive many repeat callers with a known mental health history, so our C3s help out in those situations. A caller experiencing a mental health crisis and requesting a mental health officer. So if someone calls up, which they do quite frequently, and they request a mental health officer, we used to send a CIT officer in the field out to speak with them. Now we transfer them directly to the crisis counselor for intervention. A caller experiencing a mental health crisis and the call does not meet the transfer criteria, if the 911 operator believes that the C3 could assist in de-escalation prior to the officer's arrival. Meaning, if it's a call where there's some violence and it's a first-person caller, our 911 operator will conference in the C3, and the C3 can help de-escalate, hopefully, the situation prior to the officer's arrival, providing a better outcome for not only the person in crisis, but also for the officers. And when this is happening, the 911 operators also plugged in and they're listening and they're updating the call, and the dispatcher is relaying the information to the officers while they're en route to a call. And lastly, second party callers concerned about the welfare of someone who has a known or potential mental health history or who is potentially suffering a mental health crisis at the time. Next slide, please. And again, this is in absence of diversion for those calls where officers must respond. The C3s can be a source of support for the caller during his or her immediate crisis, provide resources to better prepare the caller to handle future mental health related crisis, and provide information on how the callers can prepare themselves when officers arrive to de-escalate the situation, de-escalate the crisis prior to ABD arriving on scene, which creates a safer environment for the caller and the first responders, and provide additional information to the 911 operator, which would otherwise be unknown to first responders arriving on scene. Next slide, please. Now, the 911 operator process, this is a little different than and outside of the C3 process, and we implemented this on 9 December of 2019. Operators must complete a mandatory mental health field in our CAD, our computer-aided dispatch system, for every call for service. There are some exceptions where it just doesn't make sense to ask the question, i.e. a reckless driver or during an accident. So a mental health question will not be asked then, or the field will be filled out with a no. But there's a mandatory field which indicates whether a situation may include a mental health component. And the mandatory field is a drop-down field for our 911 operators, and so they can either select no for a no or unknown mental health component, yes for a confirmed or potential mental health component, or yes C3 UA, which means it was an eligible call to transfer to C3. However, the C3 was either on another call or they were not working at the time of the call. 911 operators will ask the mandatory mental health screening question on every call for service, again with a few caveats. And it's something in this order. Are you aware? Does it appear the subject is in mental health crisis? Next slide, please. Reporting, the Emergency Communications Division, we'll refer to it as division, will track all mental health calls data using two methods. One, the mental health field in CAD, or computer-aided dispatch, and two, using two new final dispositions codes for officers. So when the officers close out the call and there's a mental health component, we can track it through 10.8.11, which indicates a report was written in mental health, or 10.8.12, there was no report written, but there was a mental health component. Using a method of identification and tracking at the onset of this call for service and at the end of the call for service allows a comprehensive data set for our mental health calls answered and responded to by APD. Next slide, please. The division will include data on mental health calls for service in our monthly CompStat reports and provide quarterly overview of mental health calls to the command and executive staff during the quarterly CompStat meetings. The division also tracks the following data sets in a response time report summary and comparison charts, incident mapping, and in a dashboard view, including a percentage by priority, percentage by area command, percentage by council district, and incident counts by address. All dispatch calls for service with a verified or suspected mental health component, all C3 transferred calls, all C3 transfer eligible calls are included in this data set. Next slide, please. I think that's it. So I'm happy to take any questions the committee may have.
All right, council members. I have both the presentations pulled up. If you have questions and you want me to pull a slide. Any of the committee members, Councilmember Harper Madison, would you like to go first?
I do have a quick question. One of the last things that was said, I'm curious about what gets done with the information around the information that's gathered by council district. Who does that information benefit? How? I'm just curious about that.
So, Councilmember, right now it's just in our dashboard. I have received a few data requests for the information, and I don't remember who from now, but it is available in case there are requests, because that's one of the fields or way we track all of our 911 call data is through by sector and by council member district. So we just included it in the mental health data set and dashboard as well.
I appreciate that very much. One of the other questions that I have is, so, my colleagues and I have been having these consistent conversations about, as we look through, what it looks like for us to go through this transformative process and this reimagining process. One of the things that we're, very keenly aware of, is that we need to have a place for people to go. Right. So if we're talking about an emergent situation and somebody needs to go somewhere where there's a professional, and if it's a medication situation, if it's just a professional mental health intervention professional, then there needs to be a place. But the extension of that so often is in our conversations with people who work in the field, is that there's so often the need for sort of a more long-term, more substantive solution, including sort of intensive outpatient or, medication regulation management, that kind of thing. I wonder if there are data points that we could use when we're having these conversations, because this is mostly a state level conversation, right? And my council member Kitchen, she has so much, in the way of experience and knowledge here. I just sort of wonder if people like her who have so much in the way of knowledge and experience, subject matter expertise, and then people like me on the front end, if there's a way for us to dig through information that shows what happened as a result of some of these calls, what did people receive, and then, sort of like follow-up information, I guess is what I'm asking, like what happened as a result of the call? Did the person go to a place that was, an emergent care space, or did the person go to the emergent care space and then subsequently they got the intensive outpatient regulation around their medication? Like what happens after these calls is what I'm curious about. And if that's not a system that's currently in place, I'd like to know the why and the how do we get a better outlook on what happens as a result of the emergent call.
So, Councilmember, I think that we can answer your question here in two parts. One, I know Integral Care, as far as our diversions, they keep track and they record the outcomes of their calls for the call diversions. Two, on the emergent calls where officers are sent, reports are written, And in those reports, the officers indicate the outcome of the call and whether the person in crisis was admitted to a hospital or subsequently a mental health facility. So we have the data available. It will take a little bit of data mining, but we do track outcomes on both ends for emergent and our calls sent to our C3s and diverted from law enforcement.
Thank you for that. I appreciate it. I don't think it quite answers my question, but I also think that means that there's not like a continued system for like following exactly how it all lines up. But Councilmember Kitchen's hand is up, and I think she probably might have something to contribute to that. But thank you very much. I appreciate the response.
Thank you, Councilman Barbara Madison. I also have the 911 chart we saw in the last Public Safety Committee meeting. And when you scroll down on the count of calls by disposition, you already start to see the MH code. Is that the thing you were referring to?
Yes, sir. That is correct.
That's a part of it. And
Right.
Thank you. I appreciate that. But I think what I'm asking is both anecdotally, by way of my experience with family members who needed more, like outside of the emergent nature of the call. I think I'm just trying to figure out how we as a body can be active participants in the continuation of care, like that whole continuum. And so that's one of the questions that I'm trying to, but Ann, I see your hand. I think you have an answer.
Yeah, I'm sorry, Councilmember Madison. I wasn't trying to answer your question. I was just letting everybody know I had that data ready to display as well. Councilmember Kitchen.
Well, I think you're asking a really good question, Councilmember Harper Madison. And it's an example of some way where we can help connect the dots, because this kind of data would really be helpful in feeding into the system in the rest of the community. So there's a psychiatric stakeholders group that I'm looking forward to getting you involved with as soon as that meets again. It needs to meet again. But this kind of information shared with them can help identify the additional resources that are needed in the community. And I know that Integral Care is familiar with those, but there are other folks sitting at the table as part of that psychiatric stakeholder group, including Central Health, Integral Care, and a number of other entities in the community, and really working towards making sure that we have the resources, because you're right. I mean, that's where it falls off. People, I think, Don just mentioned that you need at least a 90-day follow-up, and you need much more than that, but there's no place for people to go. And so they just cycle back in. And so as a community, we can do a lot to connect those dots and try to work with the rest of the community through the psychiatric stakeholder groups and also other means to say, look, our data shows us that you need X number more resources. What's the plan for getting those? So anyway, thanks for bringing that up.
Councilmember Kitchen, this is Dawn. Can I just add a comment to that?
Please
Yes.
do.
Thank you. It's weird because I know you guys can't see me. But just to give you an idea, we actually do follow all of the individuals that we come in contact with, so we know where they went, where they were diverted to, if we were able to hook them up for services, if they didn't want services, or because some folks actually have their own provider as well. And then some people don't need ongoing services because we're able to help them resolve it and maintain stability in the community. But that 60% do need to be linked. But of anybody that we've had interaction with through the mobile crisis outreach team, we're tracking and we know where they are. And I think we could find a way to do a report that's an aggregate number, so it's not, revealing anybody's health information, so that we could get an idea on who went inpatient, who was, for example, who did we open up in our residential services? We have a couple of crisis residential services, and we use them a lot for MCOT and law enforcement as well as EMS to place individuals when they just need a place to go and they're not quite needing an inpatient facility, for instance. So I think I could get that data to you and kind of put it in groups or buckets so that you can get an idea of what that system looks like.
Thank you, Dawn. I think that would be very helpful. And if I may, just, offer a little bit in the way of anecdotal experience. And my family member has been very open and is comfortable with me sharing this information. But like for my particular family member, the thing that we found oftentimes was what we kept bumping up against was there's help, when it's an emergency, but there's not that continuation of service when it's not an active emergency. In which case, if there's nobody following, nobody tracking, nobody making certain that the medication is being, regulated, if there's nobody tracking whether or not there's the follow-up with the doctor, like that continuum is where we found ourselves in a situation where the emergency kept popping up, in which case then it became this, repeated sort of emergency room visit, and then this what's the word I'm looking for? When a person can't cover the cost of their healthcare expenses, and then it just kept becoming this like repeated cycle, this cyclical thing where it was just like cycling in and out of the emergency room. And so that's ultimately what it is. And I'm trying to get to the root of like, how do we get to the bottom of that? And I think you answered as much as you're able to. I think you answered my question, in which case I look forward to just continuing the conversation offline. Thank you.
Yeah, it's an interesting question for me about the role between the city and the county, and which jurisdiction should be doing what, and who's in charge, and which tax base is paying for which service. It might be another opportunity to consider some joint meetings like we did with Cap Metro, but to get us and the Commissioners Court at the same dais and talk through together who's going to handle which parts of the system. And I thought, Dawn, your point about how we could build up a whole crisis response, but if there isn't kind of a landing place, if there isn't those other two steps, I think you called stabilize and regain, you just cycle people in and out. And so that's a huge area of work. And Councilmember Harper Madison, as chair of the council's Health and Human Services Committee, I think it's more good work to be done digging into those details.
Absolutely, Chair Flanagan. Thank you for that. I appreciate it. And I think you're absolutely right. And I also think it's that conversation around indigent healthcare cost, that's how we can really sort of push it forward. If we recognize that there's so much work that we have to do on the front end to sort of absolve that cost on the back end. And you're absolutely right. So thank you for highlighting that.
I mean, it's just one of those things that when you talk about the amounts of money, and Dawn, I got a couple questions for you. And other colleagues, feel free to jump in, and I don't have to just ramble all on my own. But when you talked about the scale and the cost of scale, you talked about I'm going to bring the slide back up so we're all looking at the same one. Hold on. The ideal response slide.
Yes.
What do these percentages really mean? Because I think, remember, this is a public meeting too, and so I want to make sure the public is understanding. I'm not entirely sure I understand. So in that proposed model, when it says 100% of APD calls, we're not talking about anyone who calls 911 for APD can be diverted to integral care, right? So what is this referring to?
So this is in the field, right? So right now we can dispatch from 911, or in the field, there might be a law enforcement officer or EMS in the field requesting that we come out. And this proposed model would make sure that we had enough staffing to be available every time anybody called from in the field, and we would be available to handle every call that came in the 911 call center. By adding additional staff there, but we're actually going to get pretty close to that 100% in the requested model. We put 90 there because, it's hard to get 100%, but I was dreaming on the FY 2021, so I put 100%. But we're adding enough staff for us to be able to handle, for sure, all of the calls that are going to be coming in to 911, and that's how we're going to get that mental health professional question up front. These other numbers here, about 25% of APD calls and 40% of EMS, these are the ones that are in the field. Because right now with this expanded model, we have staffing where we can cover 24/7, but we're not partnered at 100% with law enforcement or with EMS. So there could be a time that we're tied up on a call and another officer or EMS paramedic needs help, and we wouldn't be able to get to them. So that's just kind of giving a little bit of room in that area. But the use of telehealth too is an expander of a workforce, and we could increase that to help be more available.
So just to be clear, the percent of APD calls and the percent of EMS calls is the situation where an officer or a paramedic has been dispatched to a call, and once they get there, they realize they need mental health support, and they make the call and somebody shows up. That's what that is.
Correct.
The CTEC calls, are those calls where you can just send mental health response?
No, this is actually just being able to field them. So if somebody calls and they say they want a mental health officer, for instance, or if we're asking the question and they say, yes, this is a mental health call, that they'll hand those calls to us and that we can field them and dispatch our own teams. So the difference would be on the FY 2021 requested model, we may or may not have the teams to send out. So that's not quite at 100%. But the proposed model would give us the ability to take the call and make sure we had enough depth in the bench to be on the scene.
But again, just to be clear, those calls are able to be responded to without an APD presence. Is that right?
Yes, if we're able to take them, those are call center calls, 911 calls.
But you don't have to send an officer too. These are calls where you can just send your team.
That's the hope, yes, sir.
Yeah, because that's obviously part of the diversion question as we think about the share of resources is when are you sending an officer, when are you not sending an officer? Mayor Adler and then Councilmember Kitchen.
And I apologize if you've already asked this question. This is really helpful. I understand increasing the capacity means that we have more of the EMS where we want EMS on the call. How does that impact, if it does, the amount of time that's required from APD or the number of officers required of APD? Does this diminish the workload for APD or the number of officers, or is it just a function of having more people there with greater range of expertise?
Well, if we're fielding the calls and dispatching, then that means APD is not involved at all. And I think this year we were able to see that 85.4% of the time, law enforcement did not have to go of the calls that we were able to field on our own.
And would those have been calls that ordinarily APD would have fielded and gone?
Yes, APD or EMS, yes, sir.
Okay. Have you written that down, that statistic or that analysis anywhere that I can see?
Yes, sir.
If you could send that to me and to the others, that would be helpful.
Sure.
Thank you.
Councilmember Kitchen.
Thank you, Don. This is very helpful. As I understand, what we're saying is that with the funding that we just voted on, we are to the point where we think we can answer all the diversion calls through 911 call center. The issue is where you get calls from other sources, like you said. If you get, I think Chair Flanagan gave a good example of that. So if someone goes out, like APD or EMS goes out and then realizes they need a mental health person, that's where we could use, where you're thinking that you could potentially use some more funding for the EMCOT personnel, I guess.
Yes, ma'am.
That's the understanding, right?
Yes,
right?
Correct.
Okay, so I have a question now about if we want to move to another slide. I wanted to talk some more about the dispatch protocol that we just went through. I'm wondering, I'm thinking that you're telling us that is the current dispatch protocol. And I'm wondering to the extent that there's room for any of those list of items that are not dispatched through a counselor. Yeah, not eligible for C3 intervention. So I'm wondering, is the thinking that over time some of these might be, or these, or have you, because I know there was a change in the protocol a few months ago that you originally started with a more conservative, smaller protocol and then expanded it some. Is the thinking that some of these might be able to be expanded at some point?
Councilmember Kitchen, unfortunately, no, because we are at the point where we have included every non-emergency, non-imminent threat to life or property type of call we can to divert to the C3. Last month, we added the check welfare urgent with a second party caller. Normally, officers would have responded to those. Since we added those, we've seen a almost double in call volume of the transfers to the C3. So it's working out well. You know, there's always room for improvement, and so I don't want to say, you know, absolutely not. However, the vast majority of calls we are excluding from transfer are those imminent risk calls where someone is hurting themselves or they're hurting someone else, and those we cannot transfer to a crisis counselor. Does that make sense?
Yeah, I have a question about a few items on this list to help me understand what they entail. So, so I think it's the last three that I have. Like when an individual has committed a crime, I understand the family violence, but I'm wondering how the term crime is interpreted and if it includes property crimes. And then I'm not certain what a hot shot call is or a priority one call. So if you could speak to those three bullets and help a bit better what those entail.
Yes, ma'am. Well, a crime is what we're referring to there is a crime, yes, where there's been property damage and someone's calling about someone who has broken something on their property. Of course, a family violence, an assault, any crime really where an officer needs to respond and write a report, which is mandated by our current policy. Our hotshot calls are those calls where life and property are in imminent danger. Examples, disturbance hotshot where there's an active crime, where there's an active fight going on. Crash hotshots where we have people injured involved in a collision. Priority one calls are the calls where they're just short of being a hotshot call where a crime has been committed or someone has been injured, but the suspect may or may not still be on scene. The incident may or may not be still occurring, or the suspect just left, and the quicker officers can get there, there's a high probability the officers may be able to find the suspect involved in the incident, whatever it was.
One last question, Chair, and then I'll. So what I have in mind that I'm thinking of is I'm wondering. So, for example, if there's a business, for example, who has someone on their premises who's an individual who's homeless, for example, and is exhibiting behaviors that are causing some concern for the business. Are those the kind of calls that we can consider having a mental health response for? And that's the kind of example I'm trying to think about. Is there as a potential there for a mental health response?
As we are right now in the program, those are difficult, and those are things we have looked at because our counselor on scene really needs to talk with someone who's involved with the person in crisis, like a family member or the person in crisis themselves. It's very difficult for them to speak to someone not involved with the person in crisis, just a third party. However, we're hopeful in the future when we move to our phase 3 and we have the integrated EMCOT counselor with the community health paramedic, then yes, maybe we can send the team of those two to those calls instead of sending an officer. Does that make sense?
Yeah, so with the funding that we're talking about to expand the program, that might be an area that you could look at. The reason I ask about that is my concern is that, and I understand that it's hard to know when you get calls, but my concern is I do hear about situations that involve, like the situation I just mentioned, and actually involving an individual experiencing homelessness, and it may be a behavior issue. That it just seems to me that having a mental health professional involved might actually get to a more a potentially more lasting result, because those are the kinds of things that the police officers have very limited tools to deal with. So thank you.
Yes, ma'am, absolutely. And again, we're hopeful with the expansion of the program and the field units coming online. We looked at the Eugene, Oregon program, the CAHOOTS program, and some of the calls they respond to, and we could see where if we took some of their methodology and brought it here to Austin, there with the teams in the field, we would have the ability to expand those calls and divert police and send those teams to those calls instead. So there are a plethora of calls that, yes, we could hopefully expand to when we get the teams online.
Plethora. That's an excellent word. Councilmember Tovo, did I see your hand up?
Yes, thank you. I guess my first question, thank you. This is really a very extremely informative presentations from APD as well as from Integral Care. Could we please get the APD presentation emailed? I don't see it linked on today's agenda, and I need to go through some of these details a little bit more closely.
I'll make sure that staff handles that for you, Councilmember.
Great, thanks. I think it would be helpful to put it up online so that the public can get it too. So if it's possible to link it to the agenda, that'd be great. So what I'm trying to understand may be answered if I had a printout in front of me of the presentation, but I'm trying to go back and forth and really understand what the opportunities are for additional diversion. And Councilmember Kitchen, your question started to get to that. So I think my first question is for you, Dawn. As I understood the statistic that you referenced, that you indicated you'd get us additional information about, 84%, you are currently able to respond to 84% of the calls. When you're saying 84%, are you saying 84% of the calls that fit the criteria as specified by, with the exceptions as specified by APD on their slide in the C3 presentation?
So the 85.4% number is actually of the calls that dispatch transferred to us, to our clinician on the floor, and we were involved in that call. We were able to divert law enforcement away from having to respond, that 85.4%. So not every call that came in, just the ones that we received.
And are you receiving all of the calls that are eligible for C3 intervention?
During the times that we're available, right now we're not 24/7, so the expansion is going to afford us that opportunity to be 24/7. And as you heard Lieutenant Murphy present, we're working on the training of dispatch. We're providing training for them and these other protocols so that we can expand that number so more calls can be handed to us.
So I think as we, this is clearly a conversation, that began multiple budget sessions ago, and we've expanded on it, and we've had a lot of input through this budget cycle from the community. I think we're going to need some help sorting out these different pieces of information and putting them in conversation with one another. So today's presentations are a good start, but as I look at what are the additional opportunities for diversion, what I think I'm hearing is that when you go 24 hours, you're doing 84% of the calls that you get currently. So there's that 16% that could be responded to with a mental health professional. Then when you go 24/7, there'll be additional calls to which you can respond. But there will always be a universe of calls that require a police response. And I think that we need to understand kind of how that all shakes out. Of the total calls, how many? Okay.
Yes,
all right. So there is still some additional opportunity.
Yes, ma'am.
It sounds like you believe the new resources will allow you to meet that opportunity.
Right. I think we're going to get closer with that, but Texas law does state that there will be times, you heard Ken talk about individuals who are at risk of harm themselves or others, right? And so if we're in need of assistance for an involuntary admission for an inpatient stay, We would still need to have law enforcement respond because we'll need them to do that because they're the only ones that are capable of providing that service for us.
That was one of my questions, so thank you for answering it. I knew there were just certain professionals who could do involuntary commitments, and I know police officers are one of those professionals, and it sounds as if your staff are not. So
No,
they would need to be. Okay, thank you.
Not yet, not unless we're able to get some changes through legislation. Other states allow social workers or licensed professional staff to provide that intervention, but Texas does not. I mean, one thing that we could look at doing to further it, and we do a lot of it already, is looking at policy and working with APD on doing a consult with us so that you at least have the mental health person on the line kind of evaluating with them the need, because sometimes we automatically go to the highest level of needing to take them to inpatient when really if we can just get on the phone with each other and come up with other resources, we can divert them to a lower level of care.
Thank you.
Yes, ma'am.
And then I had a couple other questions, and these are, I think, for both of you. Well, your presentation talks about, one, I just want to be clear that the mental health officer, when we're talking about mental health officers, those are your professionals. Is that correct? The professionals employed by Integral Care?
No, the mental health officers are actually APD. Some of them are CIT certified, but I think that's how we're looking at that. They have the either CIT certification or the extra training related to mental health.
Thanks. I think and there may be, I think in the past we've gotten various memos and things. It would be super helpful at some point to have a real clear, some kind of real clear guide to all the terminology if one doesn't already exist. So those mental health officers who have the CIT training, who are CIT officers and have that extra training, can you talk a little bit about the extent to which, and this I think, well, what kind of training are you providing to officers? And then if we could turn the question back to Assistant Chief Chacon to address that question to, or your staff member as designated, to talk a little bit about the extent to which the force more generally is trained in trauma-informed care and responses. So Dawn, if Dawn could answer the question first, the kind of training that was referenced in your slide, and then if we could hear from APD about kind of those who are not CIT officers or mental health officers, but have received training.
Sure. So right now we provide training for all of the new cadets that are coming in. We've done mental health training for actually the entire police force, I think, at this point. And what we've done to date is really around signs and symptoms of how to recognize if someone is struggling and might have a mental illness. But this has been really tailored towards what their state mandated training requires. We've done additional work with them to do vignettes and to do practice, right? And have been involved in doing some like pre and post testing to make sure that there's competencies and skills there that they were able to practice kind of what they learned in those sessions. But what we're doing today with the call takers to help improve the calls that we receive is we're actually helping the call centers become mental health first aid certified. They'll get a certificate because we're doing the full curriculum of mental health first aid, which is a very, very good curriculum. And it actually, we came to this training to be chosen for them through the work with the advocates. We had the Justice Coalition and grassroots membership at the meeting to help us kind of look at what would be an appropriate training. They too went through the training and decided that it's an evidence-based curriculum. And it really is in depth, and it allows a much broader reach than what we've traditionally done with the rest of the police force.
Great. And I'm not sure who the appropriate person is to ask, but I think it would be great if we got some additional information about what kind of training is provided as part of the Cadet Academy, and what kind of ongoing training is provided to our force.
Yes,
That would just be I think that's important for the public to know as well, just because it, again, has been a real conversation.
Yes, ma'am. From the mental health part, we're definitely on the syllabus, and we can give you the list of the exact training that we are providing and the number of hours related to mental health.
That's super. Thank you so much. And then if I could just turn it back to APD. I think they had started a response.
So with regard to the training that all of our officers receive for mental health response, and we'll use the terms crisis intervention officer or crisis intervention team and mental health officer interchangeably. At one point, they were referred to as MHOs, and now it's CIT. However, we do provide 80 hours going forward, especially at this point, 80 hours of CIT training to all of our officers. 40 hours is the basic course, and that's provided during the academy, during their cadet instruction. And then once cadets graduate, they receive the intermediate or that second piece of the CIT training towards the end of their probationary period. Our officers don't begin doing emergency detentions or emergency commitments until they're off probation, and so we schedule that a little bit later on in their cadet in their training process, so that it's fresh in their minds and that they understand all the protocols. We have about 220 officers on our department that are designated to receive a CIT stipend and are designated as CIT officers. Those are the ones that we know as a department have already received the full 80 hours. The remainder who have only maybe received the first 40, we're catching them up right now. COVID has kind of put a little bit of a halt on that, or put a crimp in it because of not being able to gather in classrooms. And what Dawn was talking about with doing the role play and the scenario based training is extremely important for that kind of training. And so we are trying to catch up in that. We had hoped to have everybody trained up by early next year. It's probably going to be a little bit longer than that now, but we do have a good number of people on patrol right now have received the full 80 hours of training and can do an emergency detention if necessary.
Great, thank you. Thank you for clearing up. Oh, sorry. Sorry, I forgot I'm using two different ways of talking. Anyway, thank you very much for that additional information. Thanks for clearing up the CIT MHO, that they are one and the same, and that the preferred term at this point is CIT. So that helps clarify some of this info for me.
Mayor Pro Tem, did I see your hand up earlier?
Yeah, I'm trying to reconcile a response to something that the mayor asked with something that Councilmember Tobo just asked. I thought the answer to the question of the 85% is the percentage of calls that the CTEC gets sent to them directly, and I thought, was it Dawn? I'm sorry if I forgot.
That's correct.
Dawn said that those calls do get diverted from APD, but then I thought Councilmember Tobo's question said that those people in those calls are still APD, or is trying to understand the diversion. The 85%, are those police officers that respond just with higher training, or they're not?
No, that's our staff. That's EMCOT. So we're responding. That 85 number represents a mental health professional going out in place of law enforcement.
Okay, so those aren't police officers at all.
Right.
And so the person that takes the call is not APD, and the person that responds is not APD. Is that right?
Correct. It comes in through 911, so it goes through the dispatch process. They identify it as a mental health call. They transfer to our clinician on the floor with them, and we take it from there.
Okay. And then this is just a bigger, I guess, question for everybody as we brainstorming, and this, I feel like this is where Councilmember Tovo was kind of going in her questioning, because I remember when we first started to talk about all this diversion, and I just, from my experience as an Austin firefighter, I remember that we wouldn't even get to medical calls in some instances because along the triage and dispatch, it was found out that there was a weapon involved. So even fire, they would tell us a stage. So even fire or EMS couldn't enter a scene while the police officers kind of made sure that the scene was safe. And so when I was thinking of how we get to those calls where, you know, these are the exceptions to the CTEC for being diverted is because there's a weapon or, you know, or there was a crime committed, all those things. And so I'm interested to know if we're doing any work as we do the work to rethink our response, because almost sometimes we're doing a really good job of the low-hanging fruit, so to speak. I feel like we're on the right track. As Councilmember Tovo, we've been having these discussions, and but it's the ones that end in I guess more disastrous kinds of ways. They're the ones that's usually are triaged where there's a weapon involved or someone's reported that there's a weapon involved. And so are we doing any kind of work around researching those kinds of incidents and those calls? Because many times the mere appearance of police officers is what scares people and escalates situations, especially when someone is experiencing a mental health crisis. And so anecdotally, I have been on scenes where just the presence of a police officer changes the interaction. And so I guess my question is, are we doing some kind of work to determine how we change that part of it? Because to me, that is the big piece of the puzzle that we're trying to get at, where we want we want everyone to be safe, including the people responding. And so that's why we're not sending just mental health professionals to calls where a weapon is involved, right? How do we get the person that does show up to be the person, someone that is not immediately trained to think, I need to protect myself, I need to protect my team. Is more of a, I don't know, negotiator, but also prepared to do what needs to be done. So as you know, obviously as little people in the situation get hurt. And I don't know who that question's for, and maybe that's just a broad thought process, but if anybody can answer it, please do.
And so, Chair, if I may, Mayor Pro Tem, I think that is the stuff of the reimagining effort, particularly in this arena of how to respond better, in better ways to have better outcomes for those that are experiencing a mental health crisis, and where there's potentially one of those disqualifiers in place. So I imagine we have not started that research yet, but clearly that's on our plate to be able to see how other agencies are handling that, and how can we improve outcomes here in Austin.
I mean, I think when we did the 911, it's not the initial 911 analysis. You know, today we're talking specifically about mental health first response, and it's not entirely clear what the ratio of calls is, or the ratio of time spent by officers on these calls is, to know how far we're getting down that road. But we know it's an important component. I think there's a lot of other pieces to this. You know, how might we reimagine traffic enforcement? How might we handle the alarm, false alarm calls better, right? So there's a lot of components to it. I mean, this might be the most challenging because it relies so much on systems we don't control. Councilmember Kitchen.
Yeah, I wanted to speak to some of the research that was done as part of the Meadows report. And that doesn't mean that there's more conversation that needs to happen. Also more in the field trying things out. And I know that one of the things that you all have talked about is the clinician's role in communicating with the officer if the officer is on the scene in a circumstance like you were talking about, because I know there's been some conversation about the ability of the clinician to actually be talking with an officer in a circumstance that might fall into one of those categories where an officer needs to be on the scene. So I don't know. I know that may be an area that y'all are just now getting into, but maybe Dawn could speak to that, or one of the officers could speak to that.
Yes, ma'am. We actually are piloting that, and Lieutenant Murphy can speak to it as well. And what they're doing is they're dispatching us into the call so that if we have the individual that's escalated on the call, we're able to work on de-escalating, and the officer gets to hear the conversation. So he's aware of what the scene will look like when he gets there based on our conversation as we're trying to calm and stabilize as much as we can on the phone. Did I get that right, Ken?
Yes, ma'am, almost. They won't be able to hear the conversation. However, as the information, the 911 operator is on the phone with the crisis counselor while the crisis counselor is speaking to the person in crisis, and the 911 operator is entering the dialogue into the call text, and then the dispatcher relays the information in the call to the officer as the officer is responding. Or the officer can read it on their mobile data computer as they're responding to the call.
So I'm not suggesting that that is the perfect way to do it. I'm just suggesting that that is some ways that are being explored right now. We just encourage, and I know you all are working on this, additional exploration of that, so that you can have the benefit of the clinician's experience in being on the scene as quickly as possible and being part of the communications as quickly as possible. So thanks for asking that question, Mayor Pro Tem, because I think that does get to the heart of what we're trying to work towards as part of this.
One of the questions I had, Dawn, just to remind me of what you said and then maybe Assistant Chief, you got a part to this too, just in terms of like the scale and the cost to scale. So Dawn, you said that to scale the MCOT and the EMCOT, or is it just the EMCOT? Because I still am having a hard time keeping those two things separate. To scale that to the proposed model, it was a couple of $1 million. Was that right?
Right. So it's EMCOT. So our current expansion that you approved was 3.15 million. But the proposed, if we were wanting to make sure that we had staff available to connect for every call from anyone in the field, it's 6.2 million.
But the 3 point whatever it is that we just did,
Yes.
that we think, as I think Councilmember Kitchen said it too, that is getting us very close
Yes.
to the theoretical maximum of diversion away from law enforcement.
Yes, sir.
So that, I mean, that's a very exciting thing. But to the other part of the system, we've made that investment. We've decided to make that investment, and the public, thinks you take a vote and the things happen. Well, the budget doesn't even start till October 1. So nothing you're seeing happening today is a result of the budget vote we made, because the budget doesn't happen for another 2 months. But by going to this expanded model, expanded COT, MCOT, it will create more folks going into these other systems, right?
Yes, sir.
And those systems have not expanded yet.
That's correct.
And you, if I remember what you said correctly, to expand those systems is $8 million.
Correct. And that was just looking at outpatient services. So the legislative board, the LBB, has done analysis on what the cost is in care if you're looking at LMHAs. And so we were able to take that amount and apply it to the number of individuals that we're reaching through the crisis services, just using the expansion model. So next year, we're looking at taking on an additional 1,600 people into our system. And that would cost us $8 million to be able to serve them through any of our, whatever service package level they would fall in, because it varies from just needing to see a doctor to needing the full wraparound supports.
And does Integral Care have background information that can speak to the crisis cycle that those folks will avoid? Like, because I mean, what I'm trying to drill down to is we get X number of calls now because the expanded systems don't exist. If you build those expanded systems, that call volume should decrease, right?
That's correct. We actually did some analysis with the expanded global crisis outreach team, kind of a return on investment. If you look,
Yeah.
we have some data there that shows where some of that cost savings is by not having people hit those higher levels of like inpatient or the EDs or law enforcement or jail for that matter, if we're avoiding incarceration. And so you're able to see it costs much less to have an individual connected to a community-based service than it does in a more restrictive service or in jail, which is ultimately restrictive.
Right, and all the more reason to have the county at the table, Central Health at the table, and maybe even some of the private healthcare providers in our community, major healthcare providers that are, you know, ultimately those costs get passed on to everyone else's insurance. So all the more reason for us to be thinking about that. And when we talk about having just adopted a $1.something billion general fund budget, $8 million does not seem a ginormous amount in context for us to have effectively fully built out a system for a city of 1 million people. Is there something I'm missing? Is there more to it than what you've laid out?
Well, yeah, so 8 million is just for next year's number. So if you want to talk about every mental health call that comes through the system, right? Every call that we're not getting all the calls. So if you look at the whole city and every call there is, the number I think would be larger. I just took the expanded model because that was a number I knew what we were expecting to serve next year. And so I used that as an example. So just by expanding an additional, just under 2,000 people, it cost $8 million. But if we are able to serve even more people because we've got more folks in the field, more of the calls are coming to us and we're able to intervene, then you look at that total number and about, that 60 to 80% of those folks are the people that will need some service and they are unfunded. So that number could grow for sure.
Councilmember Kitchen.
And I think you may be talking about the services part and not the housing part of it, because for some number, it's not everybody, of course, but some percentage of those individuals are people who need more stable housing.
About 40% are.
Yeah, so the 8 million is not going to cover all the housing needs. It's going to cover the service needs.
Correct.
Yeah, so the other thing to understand is that, and that number can be quite a bit more, as we know we're experiencing from the work that we're doing around housing for individuals who are homeless. The other thing, Chair Flanagan, that would be very interesting is the table that is set at the moment to have these conversations is the Psychiatric Stakeholders Committee. And it might be interesting to charge that committee or ask that committee to take on this kind of conversation. Not that it has to be that committee, but that is the group that it's been formed that includes all of those folks that we're referring to, county, I have to go back, but they have all those players at the table and have been instrumental in bringing other resources to the community, like the Guy Herman Center was something that was worked on through that entity. So I think it'd be helpful to talk with that group, and the leads there are Central Health and Integral Care about partnering with us to address these kinds of concerns that we're talking about.
I think that's a really good idea, and I think it's a great segue to talk to our deputy city manager. I think there's a lot of value in the kind of public conversation that we do through the committee or you do in a council meeting, and so there's probably value in having those kind of joint jurisdictional meetings in a forum that's broadcast to the public and archived on video. But then there's also like the rest of the work you got to do, because you're not actually going to do this 3 hours every other week. And it sounds like that psychiatric, what was it called? Psychiatric?
It's the Psychiatric Stakeholders Committee, and it's chaired by David Evans from Integral Health, and the Executive Director of Central Health.
Yeah, and so that sounds like a really great parallel process where you get the kind of the policymakers who have to set annual budgets where most of this funding and most of the expenses lie. You know, if you're not appropriately funding the mental health system, then you're definitely funding a lot of crisis response. To have that conversation and the table set with the electeds who set the budgets in addition to the kind of private working groups. Deputy City Manager Rivera, would you please kind of give us an update on the task force and working group stuff that the manager's office is doing?
Sure. Thank you. Councilmember Flanagan. I appreciate the opportunity, and I think Assistant City Manager Ariana was right in terms of this is an effort that we certainly have envisioned in that reimagining bucket. But these meetings are tremendously useful as we move forward to really set sort of the stage of some of the questions we're already asking ourselves. It is kind of a, for us at least, a precursor of a deep dive we're going to have with some of the stakeholders, including Integral Care. I'm excited to say that we're having our first city community task force meeting this evening. And so we are moving ahead fast. I had mentioned to you all that our hope was to have 3 this month, and we have in fact scheduled 3 this month. These initial ones really are about sort of onboarding and level setting and getting some preliminary information out there. We're hoping by the end of the 3 weeks to come out with a calendarization of priorities for the task force and to start to set the play for some of these work groups. I envision this is precisely the kind of deep dive that we have either with our community members or additional organizations as we move forward. I've mentioned too that we're also going to be talking to PD, and I appreciate that this committee has certainly been taking information from police staff. We need to do the same on our end and have set out some initial meetings with forensics, 911, and emergency dispatch, victim services, internal affairs, support staff. And through that, I think we're going to start to, if you will, unpeel the onion, because if you've seen as this mental health conversation, it is not about solving one end of the equation, but then it has other repercussions that go throughout community. And we want to make sure that we've looked at both of those. So I expect that today will be the beginning of some great work and that we will come back to council and this committee periodically. We plan on our end to at least provide monthly updates to all of council, but certainly are already talking to your staff, Chair Flanagan, and to the Vice Chair staff. We are trying to fold them into some of our process so that we can precisely align what we are doing and what this committee is doing, because we just see such great synergy and the ability to leverage our collective work.
Thank you. Councilmember Tovo, did you have your hand up earlier?
I did.
Sorry about that. Yes, I did. Thank you. I just had a quick comment. And the stakeholders committee is a great idea, the psychiatric stakeholders committee. And I know that they were kind of reconfiguring that so that they are really in a position to be able to make some decisions. I want to say though, just back to the point that Don raised about the need for more, as I heard it, I hope I'm summarizing it correctly, the need for more inpatient services and more assistance, longer term assistance, so that individuals have an opportunity to get those kinds of services, not just in a crisis response system. You know, I just want to make it clear to anybody watching this, you know, that is not something that the city is going to be able to achieve. You know, this is something, these are resources that we need to come from our healthcare community. These are resources that our other partners here in Austin are going to need to assist with. And I just think that's a really important point to be made. And I think others of my colleagues have sort of have referenced that as well. But we absolutely need our private healthcare community to participate in funding that solution, frankly.
Thank you, Councilmember Tovo. Completely agree. Councilmember Kitchen.
With regard to, could you speak to the task force meeting and how people can observe it? I mean, is it a public meeting? Is it being broadcast? Can you speak to that for people?
Council member, I will say that it is not a public meeting and it is not being broadcast, in part because we want to move through our work rather quickly, and because we want to create a table of a lot of candor. We have, however, talked with our facilitators, and I've mentioned this to our task force members as we had one-on-one conversations, and we'll go into that tonight, about how do we try to be, again, transparent? How do we provide listening sessions or summaries of our meetings? We want to try to be as public as we can, but also provide enough space for us to be candid with each other as we do some of this work moving forward. And we're trying to balance that. So, I appreciate the fact that there is a lot of interest. And so we will try to move forward as fast as we can and try to publish those summaries as fast as we can so everyone can share along. We have asked staff from the chair and the vice chair of this committee, because we want to be very aligned, to be observers in that meeting. And so we are hopeful that that will actually help us make sure that our two meetings are synced. It doesn't mean that we will always have the same thing happening, right? There are other topics of conversations that this body may want to have as we move our work, but we are going to try to move it forward and to keep that alignment that way. So we're hopeful in this approach, and I'm sure that that we will find out if there are other opinions or there are other thoughts about that. But we are trying to be as transparent as we can, while also providing a safe space for people to converse, because we also heard that very clearly, both from staff and our community members.
Yes, and I didn't mean to imply that it needed to be public, but I think what perhaps people don't understand, or maybe I just haven't seen it, is that what is the process for people to express their thinking or their concerns or their opinion? We've talked about that some, but I haven't seen anywhere, and I could easily be missing it, but I haven't seen anything definitive that I can tell folks that contact me, here's how you express your interest or your concerns or whatever. So we really need to understand so that we can so the public can feel like they have an avenue to participate, or at least participate through sharing their questions or their concerns or whatever. And so I know that was something that you all were going to get to, but can you speak to that? Do we
Sure.
What can we tell people?
So I would say that soon, and I can't tell you what precise day, but soon, and I hope it's this month, we will have built out something in Speak Up Austin. We will have an email that folks can send things to. We're trying to create a variety of different mechanisms for people to share their thoughts. We have also had that first listening session and are taking feedback from that first listening sessions with the commission and tweaking that so that we can move forward some information and start to have even broader listening sessions and focus groups. And we will have, when we have those set up, we will actually put those dates and put that information on this website landing page that we're creating. So there will be avenues, and all I can ask is just for a little patience as we build that out, but it will not be too much longer because we are trying to find a multitude of different ways that we can do that. I'll also say that the equity team has been working on their mini grant process so that they can also empower other community organizations to host those facilitated listening sessions as well and get us that information, creating those surveys in multiple language so that language is not a barrier to having this conversation with city staff. So we have a multitude of different avenues by which we are trying to get information, and we will continue to share that with you, get that from our task force if there are additional opportunities and ways in which to do that. But we are committed to having this dialogue with the city of Austin in its broadest sense of the word.
Any other questions? Well, I will just add, there's a lot of detail to dig in here, and at some point, it is Nuria, you and Spencer and Ray, and it is the staff's job to implement. And I think the council and the community have been very clear what we're trying to accomplish. We have asked our officers to do too many jobs. We have asked them to do things that has burdened the department in a way that is unsustainable. And we're not going to do that anymore. And so we need to better design these systems to meet the needs of the public. And Councilmember Harper-Madison, I'm going to thank you for what you said at the beginning of the meeting. When we talk about the community, we are inclusive of every person that lives in this community. And, I find myself sometimes laughing where people think council members are like congressmen, where we go off and you're in another city, 1,000 miles away. I mean, we're going to run into you at the grocery store. Like, we live in this community every day too. And we're not that far away. In fact, that's the beauty of the 10-1 system, is that as council members, we are far more accessible to our districts than just about any other elected official. So I encourage, as I always do, encourage folks to reach out and email your council member. When you do that, definitely say which district you live in, because it helps us focus our attention on the folks who want to hear from their elected representative. And to the officers and to all of this work that we're doing, it is by necessity, as a pragmatic matter, going to take time. We are not laying anybody off. No one is losing their jobs. There will be, as a result of that, there will be time to design these systems, to roll them out. And I thought one of the things that excited me about the presentation today was how these solutions scale incrementally. It is not all on or all off. It's not like building a hospital that you don't get to use it until it's completely built out. You can add one more staff. You can divert another 10% of the calls. You can actually scale these solutions up. And I think that, to my mind, that is the work that we are going to continue to do. It will happen on mental health first response. It will happen as we get through our 911 call analysis and we start learning other ways to unburden officers from all of the other work that don't need to be officers and let them focus on the work that does need to be officers, if not because it is a requirement of state law, but because the training can be specifically designed for officers to be specifically experts at those jobs. And I just hope that folks are listening. And I know a lot of the media folks are listening, and there's been, frankly, a lot of great reporting and then a little bit of less than great reporting. Actually, the content of the articles are great. It's the headlines that stink. The headlines are terrible. The content of the articles tend to be pretty good. But I just want, everyone's just got to keep reading and keep learning and join the council on this journey. As Councilmember Harper-Madison said, we're going to lead the country on this. And we're going to lead it, not that we did it fast and not that we did it the most, but that we did it the best. That's why Austin's going to lead. Councilmember Kassar.
Thank you, Chair. I think that's spot on. And as we come up with more meetings, I do think that finding ways to make sure everything we passed gets implemented is really important, because the only way for the theory to hold true that there's going to be fewer 911 calls and less harm is if the things we reinvested money into are implemented correctly, thoroughly, and on schedule. We actually have to get the homelessness solutions online at a faster clip than we've been able to before. We have to get this mental health response going at scale and ramped up the way described. We have to actually get the family violence shelter open and staffed and get that RFP. We have to do those things, because otherwise the structure of what council put together only works if we actually are preventing the violence and harm through our proactive interventions, which was part of the promise. And so us continuing to have these meetings, I think is a helpful way so that we all can check in on progress, hold ourselves accountable, and get it done. So again, I'm so grateful for having sort of revived this committee in this way. And so thanks to everybody for participating.
Thank you, Councilmember. Councilmember Harper-Madison.
Thank you, Chair. I couldn't be more grateful to be surrounded by people who are so much more eloquently spoken than I am. Somebody said the other night, you don't want to follow Councilmember Harper-Madison, but I just I just say what I'm thinking and I say what I'm feeling. And that is not always a good thing. And so I will say that I appreciate that I have colleagues who say things that are just so much more eloquently spoken. You and Councilmember Kassar both made reference to things that I think people really, really need to know. And at the end of the day, if we had to make a short story long, what we're telling folks is we hear you, we see you. You are important, you are valued, and your contribution to the conversation is not lost on us. And I'm not just talking about the people, I'm not just talking about the cops. And the truth of the matter is, there's no space where the cops and the people are separate folks. They're the same people. They're the people that live in your neighborhoods. They're the people who proudly serve their communities. There's no difference. So when people say this crazy thing about like either side or one side or the other, what are you talking about? We're all the same person. It's all the same people. There's no opposing sides by way of us talking about the relevance of the people who serve our community and the people who live in our communities. It's all the same people. So I really appreciate that y'all are so smart and so competent and so capable and say things in a way that I don't always have the ability to say. Thank you to all the folks who show up. I'm talking about my colleagues. Yeah, I see 9 of y'all. And a kid. I see you, kid. Don't run away. And a kid. Thank y'all for showing up all the time to do this really hard job. And I would extend that to say thank you to law enforcement officers and people in that public safety professional perspective. Thank y'all for showing up to do a really hard job. If anybody has told you that the council, we as a body, we don't like you, we hate you, whatever the nasty thing is that they told you, please walk that back. Don't listen to these people that are telling you things that aren't true. We all do a really hard job, and we include you in that perspective in terms of consideration. We know that you do a really hard job too. We're all doing really hard jobs, and we all do it, most of us do it because we believe in the work. We believe in the people that we represent and show up for. So keep showing up, keep representing. And let's keep talking to one another, because if we don't, then people say things that aren't true. And then, hush, little dog. And then you may or may not believe it. Don't believe things that aren't true. We appreciate you. We appreciate all of us doing these hard public service jobs. You think we make enough money to do these jobs for ego? Get out of here with that. We don't even make enough money to do these jobs for ego. We do it because we believe it's the right thing to do. So thank everybody who keeps showing up to do the hard jobs for not enough money. And with that, thank you, Chair. I appreciate you recognizing me.
Thank you, Council Member. Any other final comments or questions? That's a perfect place to end. Assistant Chief Chacon and Hoffmeister and Sergeant King and Lieutenant Murphy and Dawn, thank you all for joining us in our meeting today. I think this was really productive. A lot of great work. Integral Care is doing great stuff. I'm glad that we were able to move the needle on these investments last week. And it sounds like there's a lot more work yet to be done. Of course, we already all knew that. So without objection, it is 4:24 p.m. We are adjourning this meeting of the Public Safety Committee. Thanks, everybody.
Put them horns. Hey, Rosie, I'm hungry. I got a hankering for some barbecues. Ooh, how about some Tex-Mex? Flaco Jimenez is at Jovitas. Or two-stepping at the Broken Smoke, you know he plays every Thursday night. Let's not burn ourselves out. We better pace ourselves. It's not even the weekend yet. I know, and Joe Ely's at the Cactus. Let's go sit in, Rosie. Oh, I can feel the spirit of Doug's song. Stevie Ray Vaughan. Woo! What a great place to live.